Welcome, everyone. Thank you for joining us for the second session in the Canadian Breast Cancer Network's new virtual series, Questions and Experts. I'm Jen Gordon, Director of Operations with the Canadian Breast Cancer Network, and I'm pleased to welcome everyone to the session today. For those of you who may be interested in previously recorded Q&A sessions or patient education sessions, these recordings are available on CBCN's website, and I've actually just posted the link in the chat, so you'll be able to click through to that. Along with this session, CBCN will be hosting future sessions in a similar format. So Q&A, where you'll get to ask your questions to the experts, including another medical oncologist answering questions about triple-negative breast cancer, a surgical oncologist, a drug access navigator, and a naturopathic doctor. And you can subscribe to CBCN's e-newsletter. The link is provided also in the chat to be notified of these upcoming sessions that'll take place throughout the year. I'd like to extend our sincere appreciation for our sponsors for this session, our gold level sponsor, Viatris, our silver level sponsors, Pfizer Oncology and Roche, and our bronze level sponsors, AstraZeneca, Knight Therapeutics, Merck, and the Ontario Trillium Foundation. I would now like to welcome the host for this session, Kathy Mandalea, who is the chair of the board for the Canadian Breast Cancer Network. And as someone who's personally experienced a breast cancer diagnosis, Kathy really understands firsthand the importance of having all of the information you need to make informed treatment decisions. In her volunteer role as the chair of our board, Kathy works to ensure that the lived experience of people living with breast cancer inform decision makers and policies that impact patients right across the country. So Kathy, welcome, and over to you.
Thanks, Jen. So I'm pleased again to be able to host a second session in the Questions and Experts series. Our HER2 positive session held earlier this month generated incredible questions and an excellent discussion. And I know today's session will be similar with Dr. Sehdev. Questions can be submitted throughout the session using the Q&A icon at the bottom of your screen. I'm honored to welcome medical oncologist Dr. Sandeep Sehdev, who obtained his MD at the University of Ottawa. He began his internal medicine training at the Western University before his oncology training in Toronto, where he served as chief resident in 1991. He worked at the William Osler Health System, serving Brampton, Etobicoke, Orangeville, and Environ from 1991 to 2016, where he was director of continuing health education in oncology and clinical trials program. Dr. Sehdev currently practices medical oncology at the Ottawa Hospital Cancer Center. He is also a clinical investigator at the Ottawa Hospital Cancer Center. His interests lie in medical education, patient and community education, applications of technology and oncology, and advocacy. We have some questions already submitted in advance, so we will answer a couple of these to start the conversation, while additional questions are submitted through the Q&A. So obviously COVID-19 and the vaccine are top of mind for everyone. So why don't we address these questions right at the start? Let's get these going. So question one, someone submitted, I have read new research from the UK highlights the need for the second dose of the COVID-19 vaccine to be administered within 3 weeks for cancer patients. Will this be the recommendation in Canada as well?
So it's a good question. I mean, we always are trying to go with evidence, right? And we don't really have level one perfect evidence specifically in cancer patients saying there's a difference if they get it later or they get it sooner. On the one hand, we're interested in societal benefits of vaccinating as many people in the whole country as we can right away. So mine has been delayed by 3 months after my first one, for example. Most of my staff has been delayed. Right now, we don't really have evidence that for cancer patients it makes any particular difference, although it's very hard to do a special randomized trial just in breast cancer patients, for example. So I think the compromise that's been recommended even by Cancer Care Ontario in Canada and many cancer agencies internationally has been that when there are patients at particularly higher risk of infection, people receiving chemotherapy or active chemotherapy or recent chemotherapy or immunotherapy, particularly for blood cancers like leukemia, lymphoma, there we should make an effort to try to give the second dose within 3 weeks. Not because we know it's necessarily better, but because we'd rather not take a chance. And those patients are especially vulnerable, and we like to do things by the book. So currently, at least in Ottawa, patients who have received recent chemotherapy, we are trying, and it's happening in a semi-automatic fashion. Patients are getting emails automatically through our web portal and invited to come back for the second dose. Tamoxifen or endocrine therapies don't really count like chemotherapy. They're not considered as, they don't really have immune suppressive effects. So the risk is probably not that much higher than the average population. So I think if someone's on hormone therapy or anti-estrogen therapy, the risk is not as pronounced.
So just to add a little bit on that, the confusion is, to some people, having had the cancer diagnosis, even after X amount of years, they think they fall under that category of urgency to get this second dose as quickly as possible. And
Right.
in this, and second to that, the standardized approach, do we know what it is across Canada? Like you say, in Ottawa, XXX, but what about the cancer centers across the country?
So as people have noticed, the recommendations are often in flux. They're changing pretty often.
Yes.
They're based upon just kind of a seat of the pants, I think, feeling of what is optimal. So if someone's had chemotherapy and finished chemotherapy within 6 months, that's kind of an arbitrary cutoff. I mean, to me, scientifically, the risk is higher if they're actually on chemo or they've had chemo in the last few weeks. I don't think chemo 6 months ago would render their immune system weaker at this point. But they're trying to make some kind of consensus that's easy to track and implement. So I think that's what we're going with now. We're going by the Cancer Care Ontario recommendations. I can send them to you to post if you don't have them, but they're a recent draft that came out last Friday.
That would be very
Thank
good
you.
to have.
Yeah.
But and then again, there's also the added of the comorbidities in patients,
Right.
and how that affects the patient. So it's not to say one patient is going to be the same as the other, correct? Like
Right.
there
Those
are
policies
differences.
would come more from the family doctor, like just as someone who has Parkinson's, dementia, heart failure, emphysema, asthma, they would fall into that same basket. And right now, I don't think that they just have enough vaccine to allow for those other issues. They're having to go by age, and within age and within geographic hotspots, trying to allocate them the best they can. When they have enough vaccine, like America, I think just today has announced any American now can get the vaccine. They opened the gates up just today.
Yes.
So when we have enough, I think we'll be okay. We just haven't got enough yet.
Yeah, very good. So second question around the same thing, the COVID. Is there a possibility of an increased risk of blood clots from the AstraZeneca, the AZ vaccine, among those who take tamoxifen, since tamoxifen has its own risk of blood clots?
Yes, it's a good question. I mean, patients who have tamoxifen, we tell them usually their risk of blood clots is about the same as most women on the birth control pill. So I think most women on the birth control pill aren't so much even thinking about it, in day-to-day practice. They get their COVID vaccine. So it's not that different than normal women who don't have cancer. I understand where they're coming from because we do talk about that small risk when we start tamoxifen, and people are quite right to ask for it. I think it was the Globe and Mail journalist or maybe a TV journalist that made the point, though, that the risk of actually dying on the way to the vaccine clinic of a car accident is actually higher than the risk of having that kind of serious clot. So it's extremely rare right now. The benefits of the vaccine to help prevent life-threatening COVID, I think, exceed that very small risk. So if you're in a younger population where you're not on chemotherapy, where you can get that vaccine first, currently international guidelines are recommending just get any vaccine that you can, so we can get protected, both yourself and societally, as soon as possible. Those guidelines may be evolving also, but they're extremely rare events right now.
So I would imagine working with breast cancer, they're women, obviously, mostly, and the AZ is a problem, mostly in women for the blood clots, as we now know. I would imagine there's a lot of concern around that, right? And a lot of questions that you as a physician must be getting from your patients.
Right. And I think, I would probably understand, even if there's a theoretical, very small risk, why someone might prefer to get the other, brand. But right now, if it was my own family, I would say, just get protected. I'm not sure whether it's touched you or your family, but I've lost an uncle or a very close friend of my dad. We always call him an uncle. He had Parkinson's and died of COVID. So it really is happening. I think a lot of people don't really, unless they're touched by a death, they don't really understand the impact of COVID. Our nurses are in tears because they're having to hold people's hands dying, young people dying with an iPad to see their spouses before they're intubated. Like, it is really a big deal. The surgeons are being taken out of the OR to help do nursing care because they haven't got enough nurses. This is really a crisis. I mean, children's hospitals are taking care of adults now. We're bringing in doctors from other provinces to help who have no training in ICU. This is an emergency. So what we can do to protect ourselves from COVID probably trumps all the other issues right now.
I think you make a very good point. Living it, understanding it through a real life experience, one of your loved ones or somebody that has died of COVID, is not the same as watching it on television. And like you say, you're describing what they're describing on media, right? The nurses are in tears, they're holding hands of individuals who don't have their loved ones with them. You're right. There is an element of for some people that need to experience it firsthand, God forbid. Otherwise, they don't get that sense of what we're really living in. So hopefully we'll do a lot better in terms of education. Sure. Yeah. Jen, I'm going to turn it over to you. I'm going to give you a chance to ask live questions.
Sure. So let's start with our first one. When is it indicated to give tamoxifen for more than 5 years? And this is specifically around triple positive breast cancer, but I mean, looking at triple positive and HR positive as well, obviously.
So we have, it's a good question. So when I was younger, the question was who benefits from tamoxifen? Now we know it's anyone with estrogen receptor positive breast cancer in her early stage for adjuvant therapy. The question later became, what's the optimal duration? And there were studies of 3 years versus 5, and that 5 was superior. There were fewer recurrences of breast cancer. And we thought that going longer than 5 years was actually detrimental. Old studies that were poorly done showed no further protection or maybe even a higher risk. We thought maybe it became pro-estrogenic. So now we have studies like Atlas and I think Axis that show that when you go to 10 years, the chance of recurrence is actually better. So most often though, patients who have breast cancer that are after menopause, if they go longer, they finish 3 to 5 years or 2 to 5 years of tamoxifen and the rest of it with an aromatase inhibitor. I call it the 1-2 punch. And whatever cancer cells might survive the one, you hit with a different drug. There's a slightly better chance of cure by that 1-2 punch. So we don't have to go beyond 5 years of tamoxifen. But if you're premenopausal, let's say you're 30 when you start, and you're 35 later, or you're 35 and you're 40 after 5 years, then the aromatase inhibitors may not be an option. They only work after your indefinite permanent menopause. So in premenopausal patients we think may be at higher risk or may benefit from longer therapy, we often do recommend going on to 10 years. Higher risk may be lymph node positive, for example, having other aggressive features that are kind of case by case evaluated by their oncologist. And that's kind of how we decide. As you know now, and this may come up later, in very high risk younger women, we're often putting them into menopause deliberately to help lower their risk of recurrence. And in that case, they also would switch over to an aromatase inhibitor and they would not need to go to 10 years of tamoxifen. So the numbers of patients that really need 10 years of tamoxifen are relatively small.
It's an evolution, sorry
Yes.
to interject, because from the early days, as you say, and I'm speaking from experience, it was, one definition on how to treat the women with tamoxifen, and then, the Femara or, whatever they're given. And then over time, there was so many changes. And I feel that's where the confusion comes, because if somebody knows somebody that was diagnosed 20 years ago, they would get a different history from that friend or family member, right? So that's where I feel the confusion comes around, because it's not that the doctors have changed their minds. It's as we go along, we become a little better knowledgeable on how to treat and what to give, et cetera, et cetera. So it's a question that's often asked.
In the early 90s in England, they didn't check ER or PR. they gave all women tamoxifen if they were over 50. They just assumed most of them were ER positive, so let's just use it. And that evolved over time. They also didn't give tamoxifen unless you were node positive. And they only gave it after menopause. If you're premenopausal, they didn't give it at all. That was my training years in medical school. So you're right, things do change and improve because we have tens of thousands of women, just like our patients, who've been on these clinical trials where half have one way, half have the other, and we see constantly improving evidence.
Jen?
I think that's
Yeah.
I think that's great. That's really helpful, and that sort of addresses the evolution of a lot of the cancer care. Kathy, back to you for
Sure. Okay, I thought you had another question. Sorry. Okay, so I have another question. So this question reads, I have been on Arimidex for close to 10 years after a stage 1 breast cancer diagnosis, chemo and radiation. Is there any scientific evidence to continue taking this medication past 10 years? And there we go, again, into that same theme.
Right. So not really. There have been studies of longer and longer durations of therapy. The problem is you have diminishing returns. And if any slight benefit might be there, it's more in a slight reduction of the risk of getting another new cancer. It's not in saving someone's life from the cancer spreading. And most women will take longer therapy if it's life-saving. Now, when you go beyond 10 years, the cumulative risk of side effects starts to increase. You're older by then, the risk of osteoporosis from estrogen deprivation increases. That can lead to a fall when you're older, a broken hip, that can be fatal. So, most oncologists don't recommend going beyond 10 years in anybody, because then you get past that diminishing return. The majority of the benefit is in the first 5. After 5, there's a slightly less benefit. If you're stage 1, even going from 5 to 10, the biggest benefit is in lowering the chance of getting another new breast cancer. The benefit of saving your life from the old stage 1 spreading in your body is vanishingly small. So beyond 10, I think it would not be recommended usually.
Okay. Next question I have. In women who have high estrogen proliferation greater than 90%, do they benefit more from endocrine therapy than those with 50% estrogen proliferation? And if so, is high proliferation an indicator for extending endocrine therapy for 10 years? So this is the same question in a different...
Yeah. And so I think that word proliferation may be mistaken.
Yes.
We talk about what percentage of the cancer cells have these estrogen receptors. So I tell patients receptors are like keyholes that estrogen goes in through. And estrogen instructs the breast when to make milk. It tells the uterus and ovaries when to have a cycle. So those keyholes are usually on healthy breast cells. If they're on more than 90% of cancer cells, that is a good feature, suggesting a slower kind of cancer. And it means that anti-estrogens like tamoxifen and anastrozole can make a big difference in preventing the cancer recurrence. Proliferation is an entirely different thing. That's how fast are the cells dividing. And that has more to do with the benefits of chemotherapy. So if the cells at 90% have estrogen receptors, that is a particularly sensitive cell to hormone therapy. However, even if 1% have estrogen receptors, international guidelines now recommend still giving drugs like anastrozole or Arimidex, tamoxifen, because there is still a benefit. It's not a chunk benefit like where it goes from 90 to 50 to 10, but the benefit is less as you go lower, and there's more benefit as you go higher. Because the more sensitive the cells are to estrogen, intuitively, the better bang for the buck you'll get by lowering estrogen. And anastrozole lowers estrogen. I always tell patients that tamoxifen is like a master key that goes into that keyhole and breaks off the key. It blocks the door. And the other drugs, the aromatase inhibitors, work by taking away the key. They lower that little bit of estrogen after menopause to help not feed any cancer cells that could still be left. So the higher the number, the bigger the benefit. The lower, the less benefit, but it never makes it useless. It's always helpful to try these medications anyways. They do have some benefit, even at 1%.
Great, thank you. Jen, you have live questions?
We do. We have a couple more around tamoxifen. No surprise there. If you do not have any or a lot of side effects while on tamoxifen, does this mean that it's not working? Is that a way to gauge how effective it is for you personally?
That is a question we hear a lot, even on chemo. If some patients don't lose their hair, don't throw up, they're working, they wonder, maybe it's not getting into me. And that is not true. It's actually a good thing not to have side effects. And why some people get side effects and some don't, we don't fully understand yet. There could be differences in our genes and how we handle drugs, for example. If people don't get any side effects, that's a good thing. In fact, most patients do not get difficult side effects. Now, you wouldn't know that on the blogs, because on the blogs, people generally go on when they are having a problem to share their experiences, to learn from other people. The people with no side effects are busy living their lives, they're working, they don't go on blogs. So I think we tend to see an amplified voice of people with side effects and those who want to educate other women and support other women. But a lot of women don't have side effects. And if they are, they're often just those, really troublesome things like hot flashes that aren't dangerous, but they're just really annoying.
Would that be the same for chemotherapy? Like if you have chemotherapy and, for instance, I'll go with neutropenia.
Yes.
People who get their, neutrophils wiped out because of, their chemotherapy, is that a better success story that the chemotherapy has worked at a higher rate, or is that not an indicator at all?
Probably not today. There's an older regimen of chemo called CMF that we still use sometimes. It's as good as newer ones in certain cancers. And the CMF, we didn't have growth factors to kick up the white cells in those days. So if your blood counts were low, we had to slash the dose of the chemo. And they found that in people that had neutropenia, they actually had a better chance of cure. It probably meant they were getting more chemo into them. But what they used was they did weekly blood counts, which we don't do anymore. And they went by the bottom of the valley. So the very low blood count seemed to correlate to a better cure rate. That was reflecting what's called dose intensity. Those patients were probably getting pound for pound a higher amount of chemo in their bodies than other patients were. But nowadays, we use growth factors, we use medicines to kick up the white cells, so everyone is getting the proper dose without dose reductions. And we've not really seen a correlation today with modern regimens. Doses are pretty intense, they're pretty standard, and I think we're seeing pretty consistent high cure rates. There's probably other factors, more about the tumor biology, about why some people don't benefit and some do, but not just because of the strength of the dose.
I think that speaks a lot to, there's another question here around sort of the efficacy of a treatment and how you tell if it's working or not. And someone's mentioned, some women do recur while they're on tamoxifen. So is there a way to tell if it's working for you or if it's not? And why does it work for some women and not for others? Are you able to speak a little bit to that?
Sure.
It's a fairly complex question.
It's a very common question. So, when people have metastatic disease where the cancer has spread, you could just measure the tumors and see it's working. But a lot of our tamoxifen and aromatase inhibitors are given in an adjuvant setting to prevent recurrence. And when you're preventing something, you cannot tell if it's working. You can tell because, again, studies of tens of thousands of women who have had the medicine and have had a dummy pill, that the patients who had the medicine, the chance of recurrence was cut by half. So we know it's working in general. And I give the example to patients with my type 2 diabetes. I'm taking, sugar pills, blood pressure pills. My cholesterol is driven down to lower than normal numbers deliberately. And I'm taking all those things so I don't get a heart attack or stroke over, I'm taking them my whole life. It's already been 20 years. So if I don't have a heart attack or stroke, to me, they're working. It's for prevention. These pills, in a way, are pretty magic, because they're often only for a few years. And they much more dramatically help prevent death from cancer than my pills do for 20 years or 30 or 40 years of the same pills to help lower my risk of heart attack or stroke. So the bang for the buck we're getting is pretty amazing for these, but it's all preventative. You cannot measure in one person. We're doing studies now, as you know, of taking blood samples in people to see if there's microscopic traces of circulating tumor DNA in their blood that could indicate there's some cancer there. And if they go down on the tamoxifen or anastrozole, Maybe then we know it's kind of working if it goes to zero. But many patients have such tiny amounts of cancer hiding that our medicines prevent from occurring. You wouldn't pick them up with current tests. So right now, we're not really there. As you know, we don't recommend regular body scans on a routine basis. They don't work well. We tried that in the 80s. They didn't work. The cancer came back between the scans whenever it wanted to. And finding it a little bit earlier still didn't make it curable. CAT scans have the same radiation as 400 chest x-rays at once. So doing them on a regular basis was detrimental. So right now, we don't really know if it's working, but we know, across the whole population, we're saving jumbo jet loads of lives across the country every year by people getting them.
Mm-hmm. Great. Jen, do you have any more? Should I go to the...
No, we'll go back to you and then back to a couple of the live questions.
Okay. So this next question reads, I'm 47 years old and I have been on Tamoxifen since March 2018. Recently, I've started getting my period back. Very spotty, but I never know when it will start. My oncologist says I have to be 2 solid years with no period and no signs of a period before I can have my ovaries out. What are your thoughts? So again, there's that ovary question just snuck into all this.
So it's very hard to comment on the individual cases without having their files. So I think that person needs to ask that question of their own oncologist, because some of the pieces don't fit in the puzzle. So usually we change people from tamoxifen to finish the rest of their treatment with an aromatase inhibitor after at least a couple of years. But we only can use aromatase inhibitors when they're definitely in menopause. So how do we tell they're definitely in menopause? We tell by them not having periods for 2 years. Periods often go away with chemo, but they can come back later. They can come back a year or two later. So by having no periods, we can be sure they're in permanent menopause, and then they get the benefit of switching into an aromatase inhibitor. So that's a very different question. The ovaries can come out at any age. And in fact, we often take the ovaries out when someone's 35, because that's where we're trying to really make sure the estrogen system is really cut off completely. If someone has a very high risk cancer, they're quite young, we know their periods will definitely come back. And by keeping the periods shut off, we know the chance of cure is better. So ovarian function can be turned off by taking the ovaries out, or it can be shut off with medicines at any time. But those are usually more important in women who are very young, under 40 particularly, and not necessarily when you're 47. I think the real question is the doctors could be planning to switch to an aromatase inhibitor, but they need to make sure that it's been at least 2 years, because periods can come back. If periods come back and you get switched to an aromatase inhibitor, they can be detrimental. They actually can stimulate ovaries and increase estrogen levels if you're not in menopause. So that's what probably she's thinking about.
So just to go back to the ovaries, and the question almost makes it seem that, that is a standard way of treating patients. So prophylactic ovarectomy is not a standard. It's an individual base. Correct?
It is standard to prevent ovary cancer if you have that Angelina Jolie gene, like BRCA1,
Right. The
BRCA2,
BRCAs, yes.
or other similar genes, then you want to prevent ovary cancer, right? So it's doing 2 things. But for regular women who don't have that gene that causes ovary cancer, they're not removed to prevent ovary cancer. They're removed to really induce a really deep menopause state and to guarantee menopause. And there, our international guidelines say we should give it to people less than 40 because they have many years ahead of menstruation when it comes back. And in people where their cancer was bad enough to require chemo. If their cancer was so minor, they didn't even need preventive or adjuvant chemo, then the risk is small enough, it may not be worth it. The other way to turn the ovaries off are with injections of kind of anti-hormone, or often we use Zoladex, or the real name is Goserelin, as a monthly injection in the skin through the family doctor. They're not as reliable. In some studies, 15% or so of women, if you measure them with really fancy research tools, their estrogen level is not as low as it needs to be. So a laparoscopic oophorectomy is almost like having your tubes tied. It's not a big procedure. Scope through the belly button, day procedure, home same day. That often is the more definitive way to do it.
Thank you. So I'm going to turn it over to Jen. You have some live questions.
I do, and actually on the topic of, so BRCA came up and genetic mutations, and there's a question here around the CHEK2 mutation and how much of a driver that mutation is in HR positive breast cancer, and what considerations should be given to that.
So usually if someone's found to have a CHEK2 mutation, they get a very detailed personal letter from a geneticist. Now it's pretty rare, so I've only seen that once in the last several years since we started checking for it. So it is a factor in breast cancer. Commonly, we find the gene test reporting something called a VUS, a variant of uncertain significance. So it's a mutation, but it's not one that typically has been connected with breast cancer. And those aren't the same thing. So I think that will be the best question will be addressed to the geneticist that advises the patient. Most oncologists will not even know completely about what are the other cancers that it may predispose to. We know BRCA, for example, predisposes sometimes to bowel cancer, to ovarian cancer, not particularly uterus, but we know that package pretty well. If men have it, they have a higher risk of prostate cancer also, but the other genes are much less common. So I generally, even myself, refer back to the geneticist's letter, to guide my patients.
Well, and currently we don't have any treatments that target that particular mutation, right? Like we're seeing some treatments in terms of targeting the BRCA mutation, but is there anything for the CHEK2 mutation or not?
No. So, in some studies, they're being treated similarly for metastatic patients in terms of genes that, drugs that target DNA division, DNA repair, but it's not at all certain how well they work for that kind of mutation. But I was thinking more of early breast cancer, when we're trying to cure and prevent. There for BRCA, the main additional intervention is just the surgical, taking off both breasts, taking off both ovaries to really help prevent that very high chance otherwise of getting cancer again.
Yeah. Am I next, Jen, or?
Actually, why don't we do one more live one and then back to you? This is actually something we haven't touched on yet. So are you able to speak about the role of CDK46 inhibitors, both in the metastatic space as well as whether or not they're being used in the early breast cancer space?
So metastatic, it's been pretty much a standard of care for 5 years now. It's been funded and available in Canada for, I think you would know better, Jen, but 3.5 years.
Something around there, yes, right? Yeah, in the metastatic.
They're very costly drugs. And again, I tell patients they work together with the anti-estrogens. So they're usually given with an aromatase inhibitor. If someone's younger, we try to make them menopausal with shots or with oophorectomy. And then we use an aromatase inhibitor like letrozole. And we combine that with a CDK46. So on the one hand, the hormone drug is taking away estrogen or lowering it. And the CDK46 inhibitors, basically how they work, if people remember their high school biology about mitosis, one cell dividing into two and two become four, there are built-in clock timers in the DNA that tell them when to divide. And the CDK, that are called checkpoint inhibitors for mitosis, the CDK chemicals are basically gates that activate that clock. So if we give a CDK46 inhibitor, we're kind of trying to shut off that clock timer that tells the cells when to divide. That's how they work. We thought they would work better in very fast cancers that divide quickly, like triple negative or HER2 positive breast cancers. And in fact, they found in the test tube and in animals, they work much better in these slower ER positive type. And that's where they were found to be very helpful. Patients get often mired in the numbers. So we actually sometimes show them these curves of how people do. And the most illustrative curve, if you look 2 or 3 years later, the chance of the cancer being controlled and not increasing is almost double. If we add those drugs in. They're pills, they're well tolerated. Sometimes they can make the white cells go low, but it's not like chemo. The risk of infection is negligible, less than 2%. So they really have changed things. The problem is they're very expensive. So for systems to pay for them took quite a while to get funded routinely. They're used now in the metastatic setting, mostly in the beginning, very first diagnosis of metastases. Sometimes they're used as a second treatment if someone does not want the added complexity or if they couldn't afford it for some reason. In the adjuvant setting, that's where the hot news is now from our San Antonio conference in December and ESMO last fall. There's evidence, they've looked at two drugs mostly, one called palbociclib, or Ibrance is the brand name, and the other is abemaciclib, or Verzenio is the brand name. And the palbociclib studies were negative. They did not seem to help prevent recurrence of the cancer. And the abemaciclib study showed that if you look a couple of years down the road, if people got it preventatively, there was about a 3% benefit. So it's a very difficult thing to comment on. Is 3% enough to give everybody a drug that may be $10,000 a month, for a couple of years? Can governments afford that? So the study was done mostly in people with very high risk breast cancer. Many nodes involved, like more than 4 nodes, large tumors. Now in practice, if we have patients with very bad disease, we are considering it if people have private insurance. There's no compassionate program yet to pay for it from the company. There's no government funding yet. We're somewhat lucky in Ottawa. We have a pretty well-insured employee base here from the federal government. And case by case, we do think of it. I had a patient that had preoperative chemo for very inflammatory breast cancer. And when it shrank and she had surgery, she still had 14 lymph nodes positive. So I think I'll be offering that to her after her, as her next step, if we can get it through her insurance. But I think right now it's kind of still case by case for very high risk patients, 10 nodes or more than 4 nodes with other high risk features. We should have more data on the overall survival benefit in the next couple of years. Right now, we know there's a lower chance of getting metastases. We don't know yet if it's going to actually save lives. That data will take a couple more years to come out. And if I tell some patients that there's an extra drug you can take that may improve the cure rate by 3%, I get a kind of a varied mixture of responses based on the patient's priorities. I mean, some of you may know we often give an intravenous bone strengthener called zoledronic acid to prevent recurrence of cancer, particularly in bone. That's about a 3% benefit. We do it routinely. So it's going to be challenging. The long-term data, it may not pan out. So right now, we're still kind of waiting for more information.
That's great. Sounds like it's just that high-risk population at this point in time.
I'd say even very high risk.
Mm.
Yeah, but I guess 3% is not the same for everybody. That means
exactly.
What it means to one individual
exactly.
is not the same as another. I guess
it's only for those patients that would have been candidates for the trial. So an average stage 1 patient or stage 2 patient would not have been in that category.
Right.
So they have no proof of benefit. There are potentially side effects. It can cause sometimes difficult diarrhea, for example. So that's no fun, for a year or two. So we're still trying to flesh that out.
Yeah. Well, hopefully. Okay, I'm going to go on to the next question. I don't have a family history with breast cancer. What are my daughter's chances of getting this cancer? I hear this a lot, where there's this one person who gets cancer, and in all her family, she's not had anybody. And where's that? Why is that? And that's a question that's quite not, I wouldn't say common, but it happens.
So I guess it gets back to the why me question in general, right? We often don't know why an individual gets breast cancer. And that's why we do screening mammograms on everybody who fit the criteria by age, because it can affect anyone and it affects so many people. So most patients coming to see us do not have a particular red flag why they got it. And that can make women sometimes, or men, can make them vulnerable to fraudulent, advertising. They might say it's the sugar in their food or the hydro lines or the underarm deodorant, and that's not true. It can happen to anyone. I think we look for genes, right now in most Canadian jurisdictions, testing for the genes like BRCA1, BRCA2 is funded by governments if the risk of having a gene is more than 10%. based on the family history. So, I actually offer testing to every woman because in the States, it's offered to everyone. I think in Germany and some European districts, the price of testing has come down. The whole panel is pretty expensive, but just BRCA1 or BRCA2 is about $600 to pay for it through Life Labs or through a private laboratory. You may know of the Sunnybrook and Women's College project that's supported by charity. I think it's called thescreenproject.ca. And there you can pay, I think, $150 and have it done. So some women will want to for the sake of their family. But the risk is pretty small if you don't have a family history. But I understand where women are coming from. They're well-read, they're knowledgeable, they're reading about these things online, they know it's common practice in the States. So I tell everyone about the test, but I say, look, if you can't afford it, I wouldn't push you to have it done, but it's there for your information. Most often the risk to family, however, even without the genes, is a bit higher with anything. If someone has type 2 diabetes, the risk is higher in their family. We don't know of the genes for that. It could be a combination of genetic and environmental factors. I'm not sure what Kathy or Jen, for you guys, like what do you quote patients now for a lifetime risk of breast cancer? It was 1 in 9. I heard 1 in 8 recently from the Cancer Society, right?
It goes back and forth. It went from 1 in 7, 1 in 8, 1 in 9, and
We're
I
at 1
think
in
it's
8.
1 in 8
Yeah.
now.
So if the risk is a bit higher in close family members, it might be 1 in 7 or 1 in 6 instead of, but it's not like 100%. And it just means they should be more vigilant to follow the recommendations for screening, probably start screening at a younger age and go annually, not, maybe every 2 years. Check their breast exam themselves. Breast self-examination has not been proven to make a big difference for regular people. If there's a family history, I would recommend it. I recommend more efforts on diet and lifestyle. We know that exercise can dramatically affect risk of breast cancer. No one has time for exercise, but that's important. Healthy diet, lots of fruits and vegetables, cutting back on red meats and fats. All those basic things that we should pay attention to, they should be more vigilant for. But I wouldn't think they should be frightened that they will definitely get it. They just have to be more aware and make an extra effort.
Yeah, it's just that, you hear families that have one off, one person in an entire family, and over time, no one else has had the cancer. And maybe a daughter says, what happens to my daughter? And this is where I think that the confusion comes around, because I think, like you said, patients are well read now. They understand, they automatically understand BRCA. They understand if there's a genetic feature in their family, or they're a little bit more on the lookout. And women especially, I think we have a higher level of being a little more in tune with ourselves. We're mothers. We want to make sure we're well for our children. So those are questions that are sometimes very scary and confusing.
The other good point is to remind people the risk may be a bit higher in first degree relatives. So sisters, mom, don't forget mom, and also daughters, but not nieces and cousins. It's more just one step away in the family. So I do advise vigilance, but not fear. Most people by the odds alone should have someone in the family with breast cancer because it's so common. I have a couple, but I don't suspect any gene, an aunt and a cousin, but on different arms of the family. So, it's not unusual.
Yeah, I guess there's different, in different families, I guess, different gene pools.
And by the same token, if someone does not have a gene and they've been tested and there's a big family history, I've had a friend who actually had a big family history. They couldn't find a gene. There may be genes we're not aware of yet. So she actually had both breasts taken off preventatively, which is kind of radical, but I understood, where she's coming from. When I trained, they only just discovered the second BRCA. And now we have at least 10 or 12 genes as part of our panel. There may well be more.
True. We live and we learn as we go along. I'm going to go on to the next question. What are the different anti-hormone drugs available for early stage HR positive breast cancer, and which would cause the least amount of side effects for a postmenopausal woman?
Yeah, so they're basically the two categories. We have tamoxifen you heard about, and we have the aromatase inhibitors. So tamoxifen, again, is like that master key that blocks the estrogen keyhole. So if any cells are trying to form or are hiding, they wither and die, hopefully, without the estrogen. And the aromatase inhibitors lower the estrogen. And women often ask me, after menopause, they don't make estrogen, so why do they need anything? And they always make that little trickle of male hormone their whole life at the same level. So when the ovaries shut off with menopause, the male hormone continues. So you may know some, depends on racial background as well, but some people after menopause get a bit of facial hair, a bit of balding. It's because of the male being more prominent. And not going up, but just continuing. And the body has a back door that converts a bit of that male into a bit of estrogen. That's called aromatase. And the aromatase inhibitors kind of shut the back door. So a little bit of estrogen is not made. So all the three of them we have, anastrozole, letrozole, and exemestane, all pretty much work the same way, and they're equally effective. So which one we start doesn't really matter. Most of us start with letrozole or anastrozole that have most of the, the data for giving initially. If there are side effects, we often swap them out interchangeably, but they all work the same. So the question is, which one is the most effective? We know that through a woman's journey of preventive anti-estrogens, the aromatase inhibitors after menopause should be part of that journey. So if it's 5 years, it can be the last half. If it's 10 years, it can be the last half of the 10 years. By including that as half of the journey, the long-term outcomes are about 4% better. That's worthwhile. Some people, including many oncologists in Toronto and the States, just start off with aromatase inhibitors the whole time and don't use tamoxifen at all. Because the benefits are the same if you take aromatase inhibitors the whole time, or you start with tamoxifen and switch halfway. So that really is up to the patient and oncologist. The reason a lot of us like to switch halfway is because sometimes the side effects of one kind of counteract those of the other. They're all fairly mild and usually manageable pretty easily. Tamoxifen actually helps build bone strength. Aromatase inhibitors sometimes can slightly decrease bone strength, so maybe you get a bit of canceling out. Tamoxifen can slightly increase the risk of uterus cancer, maybe 1 in 500, usually caught early and curable. Aromatase inhibitors can prevent uterine cancer. So again, you have that nice combination. Tamoxifen sometimes might cause a bit more mood swings. Aromatase inhibitors sometimes can make joint pains more achy. They don't cause arthritis. They don't make arthritis worse. They make it achier. So, maybe someone doesn't want to live with that for the whole 5 years. But if they want to get the same bang for the buck, they can take it for half the time. So those are the individual considerations. If someone has very bad osteoporosis, they might take tamoxifen the whole time. It helps bones. If they had very bad arthritis and they're really sore, if they have trouble with an aromatase inhibitor, they might just go back and finish with the tamoxifen. Most women don't have any absolute stop sign for either. And we either do half and half or do an aromatase inhibitor for the whole time. And, with careful monitoring, the side effects are largely preventable and treatable. And for all the women too, for all of them, the benefits in terms of life-saving benefit for breast cancer, preventing another breast cancer, mathematically, they outweigh the side effects dramatically. So it's not even close.
What's compliance like in either, what's compliance like? I mean,
compliance,
it's hard to gauge compliance.
Compliance is hard to gauge. In studies where they actually have a computer in the top of the bottle where you open it and it counts how often it was open, or they call pharmacists to see how often they got the refills if they didn't get them on time, they can estimate compliance. Compliance in studies is defined as how many people finish 85% of their doses over a time period. So it's only about 40%. So you think, breast cancer patients are so knowledgeable, so motivated, they want to do the right thing. You think they would be higher. But even in clinical trials where they're very motivated, they're on the study, they're being monitored, all the way through, it's about 40, 50% if you look over the whole multiple years of treatment. So one of the most important things I do when I see a follow-up patient is I ask him or her, are you taking your pill? And then I say, well, if you're taking it, have you missed any? And why did you miss them? And even if for the first 3 visits, I ask those questions, patients seem to understand that it's important to us that they don't miss it. and the message comes through. And later on, I think I had better compliance in the literature because of the extra effort just to remind people. Sometimes they just forget. They're not pill people. They don't have other pills they take. They forget during the day. Other times they worry, because they're very well informed, but also being well informed means you're knowledgeable, you're on the internet, and you can be, prey to rumors or fears that can be misplaced. When I was working in Toronto, we had a largely immigrant population, and they weren't, they were largely from India, South Asia, South America. They're laborers, hardworking people, very nice, but they weren't on the internet so much. Part of it was a language barrier, and the compliance is very high. In Ottawa, we have a very well-educated population, but I think they're also, they ask more questions, which I like, but also they can be sometimes, easy to fall prey to misinformation. The websites, when you Google breast cancer, on the first page, a good number are fraudulent, or a good number are misleading, trying to sell people on things. Or I remember I had one patient vividly, a lovely lady, she always told me she was taking her tamoxifen or her letrozole, and her cancer came back in her bones. And later, after 2 years, she said, I never really took it because I read a book by Suzanne Summers that said not to take it. Now, Jen, you're probably too young to know who Suzanne Summers was.
I know who she is.
She was an actress on a comedy show. Maybe her era's version of Gwyneth Paltrow, perhaps, like really into exercise. Her cancer was very low risk. So, for my woman with a high risk breast cancer, it's possible she died unnecessarily. It could have lowered her risk dramatically. So I really feel badly when that happens, but I think the compliance is very important. It's one thing we try to emphasize to patients. And we always tell patients, we're not here to make you suffer. Mm-hmm. If you're having problems that are bothering you, even if I think they're okay, let's address them. Let's find a way to make them milder, or let's change the treatment. But we should find a way that you can live with it, pretty easily. Maybe it's okay to tolerate some minor things like hot flashes, but if it's difficult, we'll have to decide together what to do. I've only had to stop treatment altogether and give up on therapy, maybe on 2 people in 5 years.
So it sounds like, and that speaks to one of the questions from Sandra here around, how much is your risk of recurrence increased if you're not able to tolerate an AI or tamoxifen? And so it sounds like really whatever can be done and working with your healthcare professionals to find out how to mitigate the side effects that are not tolerable is probably what needs to happen as often or as frequently as possible. And really looking at not taking those as sort of a last, to your point, you've had 2 patients that have not been able to tolerate those. So it's working with your physician, with your healthcare professionals to figure out what can be done to help it keep that.
And nowadays, family doctors are often taking over our follow-up now. So, my dad had a massive bypass operation for heart disease. And after a couple of cardiology visits, most of his follow-up is to his family doctor. They know how to manage sugar pills and cholesterol and blood pressure pills. So our GPs in our area know what to do for hot flashes, know for vaginal dryness, they know what not to do. So they're very well equipped to help women through that as well. It doesn't have to be the oncologist, but that close communication, don't suffer in silence. That communication is important. And the other thing is that not everyone needs to push it. If one woman had a 6-millimeter breast cancer, the main benefit of her taking the pill is to help prevent a new one. The chance of it saving her life from the cancer is less than 0.5%. So, if she can't tolerate that treatment, I'd rather just stop it. On the other hand, if someone had 10 nodes positive, I might say, look, I'm really worried about your cancer. It comes back, there's no cure. You have a family to live for and children, and let's just try to get through this. So it depends a little bit on the situation uniquely for that patient and how risky the cancer was.
Yeah, I guess it depends who the patient is and what the patient is going through.
Exactly.
True. 40%, that's kind of, I'm going to state my opinion. Too bad. It's only.
Yeah. I think we forget that. There are many drugs in oncology where we probably don't have great compliance, but we don't know how much of a difference it makes either. So in looking at people who comply or don't comply, if you miss, 1 in 5 doses, it doesn't matter. We don't know that.
Yeah, I wonder. Live question, or is it on to me now, Jen?
I've got a couple live ones
Oh,
here. Actually,
okay.
as reducing the risk of recurrence is obviously top of mind for so many, and especially in the hormone receptor positive space. So a very broad question here from Michelle. Can you speak about the key ways to prevent recurrence of breast cancer? So maybe we'll do, because there's so many, but maybe we'll do like a top 3 from your perspective, Dr. Sehdev, what patients can do to reduce that risk of recurrence.
Well, but being biased as a med-onc, number one are the drugs. I saw a British analyst at ASCO, a big cancer conference about 5 years ago, look at the data over the preceding 25 years. The death rate has been cut by half since I started, working back in 91. And most of that has been due to preventive adjuvant medicines. Most of that. A smaller amount has been due to early detection by mammography, which is very important. And most of it has been prevention of recurrence after breast cancer. So I think the medications that patient needs are very important. Number 2 would be radiation, obviously, if it's required after lumpectomy or sometimes after mastectomy to help prevent a local recurrence in the lymph nodes or chest. Radiation sometimes can save lives as well. It may improve the life and death cure rate by another few percentage points. And the third thing is lifestyle. We hinted at that a bit. We have tantalizing data that exercise may not only prevent new ones, but may lower the risk of recurrence of a breast cancer. We don't know how, but it's striking. It seems to lower the risk of colorectal cancer, Alzheimer's, obviously heart disease, diabetes, hypertension. So it's something that we're probably evolutionarily meant to do that we don't do. Lifestyle includes smoking. You guys know that alcohol is a bigger factor than smoking for breast cancer, so we should try to recommend alcohol avoidance, except for special occasions, or trying to keep it down to 1 or 2 drinks a week. The benefits of alcohol for heart and such are the same with, grape juice or with green tea, dark chocolate. It doesn't have to be alcohol or red wine to get the benefits to our lives. The European government has said now that there is no safe amount of alcohol. There's an increased risk of bowel cancer, of other diseases. So that's one thing I try to educate women about. So lifestyle, I think, is a big one. We don't spend enough time about that. I had a good friend, Ron McCormick, is an oncologist out in Sydney and Cape Breton. And years ago, when he gave people a prescription for the tamoxifen, he'd write a separate prescription on the old-fashioned pad. And the patients would take it to their pharmacy and it said exercise, 90 minutes a week at least. Or I think it was an hour, 90 minutes a week. And they take it, the pharmacists were perplexed, like, why are you giving this to me? But he actually prescribed it. And I think even just the fact we mention it, people actually do take it seriously if the doctor thinks enough to actually mention it to them.
Yeah, for sure. Definitely.
Well, and that's something that's variable, right? I mean, there's a couple other questions here in terms of vitamin D, particularly around vitamin D and around aspirin to reduce recurrence. Right. And should breast cancer patients be taking more vitamin D? Can you comment on a couple of those?
So I think it was Maureen Trudeau at Sunnybrook who had a big interest in that. And I think there was another oncologist at PMH. There were studies years ago that showed that women who have breast cancer, more of them had a low vitamin D level. So the actual thought was maybe if we supplement vitamin D, maybe we'll prevent breast cancer. And that was not shown. That giving vitamin D supplements does not seem to lower the risk of breast cancer. For breast cancer recurrence after you've had it, it's not been adequately studied. In fact, it may be that women who have breast cancer, the cancer metabolically somehow might lower their vitamin D levels, like a chicken and egg kind of thing, or there could be some other common factor that could be both causing breast cancer and depressing vitamin D levels, but giving more didn't help. So now you don't find family doctors measuring vitamin D levels. We never should dose vitamin D to match a blood test level. That's been kind of debunked. I recommend vitamin D because it has bone benefits. So tamoxifen in young women, aromatase inhibitors after menopause can increase the risk of bone thinning. So vitamin D and calcium are helpful. There's some mixed evidence that may lower the risk of colon cancer, of skin cancer. It's not dangerous to take it in proper quantities. I don't recommend mega doses. Some people have taken 20,000 units a day, which I think, we can cause kidney stones and metabolic complications. So I think just, 1,000 or 2,000 a day probably is reasonable to take together with calcium. for bone health. Other than that, we don't have all the answers yet. Other studies have shown mixed results about vitamin B, B complex. There was evidence that beta carotene, that kind of the vitamin A analog, that's derived from the carrot vitamin, is not really a natural vitamin. Beta carotene is a synthetic product. And beta carotene we thought might prevent cancer from test tube studies, but in fact, studies run by dietitians across Europe, North America, the UK, consistently found that in large groups of people who took multivitamins or beta carotene supplements actually had a bit more cancer, particularly lung cancer. And when 3 studies show that, there's something going on there. Vitamins are really things that are meant to be in our bodies in minute traces. When we mess with them, we don't really know what we're doing. So even though we were quite hopeful, I think now we don't recommend, aside from vitamin D, we don't recommend vitamins. If your doctor found your B12 was low, as mine was, you take a supplement. But if it wasn't low, there probably is not benefit in taking additional supplements. There was a great show on CBC Marketplace on vitamin supplements and prevention of health problems that kind of, I think, is available online.
That's good.
Yeah.
Back to you for
Okay.
a couple.
Sorry? Yeah.
We'll go back to you for the next couple questions.
Okay. So the next question, can you comment on the over-the-counter medications, i.e. supplements that should be avoided if taking tamoxifen or letrozole? Examples, Benadryl, Gravol, turmeric.
So,
There's a little bit of a mixed bag here, so.
yeah, for sure. So, turmeric may be one reason why they get less esophageal cancer in India. But the studies showing benefit for other cancers are not fully there. So you might ask your naturopath the next series of guests coming on. I'd be interested in that as well. There's probably no downside to that. Some over-the-counter medicines can affect what's called the QTc interval. It has to do with the speed of conduction of the heart pathways, the nerves in the heart. So the patients should check with their pharmacist. There's a common sleeping pill called trazodone, which doesn't go with tamoxifen because tamoxifen can affect the QTc. Usually it's more important for prescription medicines than over-the-counter ones. Aside from that, the main things we worry about are things that might have estrogen properties. So if people have hot flashes, they used to take evening primrose oil. Remember that one? It's not quite so common anymore. I used to prescribe it for patients. We used to use, what was the other one? Belladonna extract. That was actually almost like an opioid you could take in a capsule from belladonna plants that would help hot flashes. Dong Quai from China. And many times they would work, although the evening primrose oil was not much better than placebo in randomized trials. But those compounds have estrogenic properties. So we're a bit cautious, and maybe that's why they're working. So I wouldn't recommend them because they may be almost like a mild estrogen that you don't want when you've had breast cancer. People often ask about soy. So, in Japan and China, it's a bit confusing. In Japan, they eat a lot of soy, and their breast cancer rates used to be lower than ours. So we don't think it's carcinogenic or dangerous, but soy extract is different. Soy extract is a compound of concentrated soy origin, and it's given more as a drug to help hot flashes. And that we don't recommend. You're taking it like a pharmaceutical, and you could be amplifying estrogenic properties. So we don't recommend that for our patients. If there are hot flashes, let's deal with them. There are very well done trials supporting many medications that can help, that are safe, if we need to. The other ones, black cohosh, all those types of things may have estrogen properties. I remember years ago, there was a woman on a CBC call-in show talking about how her mom had breast cancer and she did not want to get breast implants because they cause cancer. She was a model and she wanted to enlarge her breasts. So she actually took some of these herbal supplements and she gained 2 cup sizes. And what she didn't realize, even though they're natural origin, they probably were dangerous for her and could have increased her risk of breast cancer. They're stimulating breast growth, whereas implants don't cause breast cancer. They can cause, very rarely, certain kinds can cause another kind of disease, but she kind of had it backwards. Many compounds, as you know now, in our environment, BPA and plastics, Flame retardants are now known to be estrogenic. They may be one reason women are having their periods starting younger and younger. Boys' sperm counts are going down in teenage years. So there's lots of things out there that have estrogenic properties we're trying to avoid. But having said that, most over-the-counter things, acetaminophen, allergy medicines, like there's not a big deal.
My only thing I would comment on is that it's important for patients to advise their medical oncologists of what they're taking that is not, within the, prescribed medications, so that, and often they think, well, it's vitamins, it's not necessary to report it. And I think that's important that people understand, report everything we take. Because
actually, it doesn't have to be the oncologist. Our pharmacists, we work as a team. So nurses and pharmacists, they get people to call in lines, they're very knowledgeable about these things. Also, I don't want people spending a fortune. Patients are vulnerable. They've been through a frightening diagnosis and they can be easily, taken advantage of. Once I was just buying something at a pharmacy, a retail pharmacy, and I overheard a pharmacist, a patient wanted to get this package of vitamins, but it was $300 a month for her mom who had had breast cancer before. And the pharmacist said to the patient, well, isn't your mom worth it? And I was really upset. I didn't say anything, but that's, it may be bad for them potentially. And there's no proof that they would do what the young person was hoping for their mom. So, it is a bit of buyer beware. There's no real regulations on those products either. It's kind of consumer beware. They're often approved and licensed under the same kind of package of laws that's used for food additives and not for drugs. One kind of defense you have is that if they make a claim on the label, the consumer laws used to mandate they have proof. Like Energizer's better than Duracell, you had to have proof. If you make a claim on a handout you stick below the shelf or a pamphlet, there's not that level of proof required. So look at the label. Make sure the label has the word standardized. That just means that someone has actually checked that the amount of the product is correct in it. The bottle is sealed properly. And things that generally come from Germany, North America, tend to have higher quality controls.
Good. Very important. I'm going to go on to the next question, Jen. Is electrotherapy available in Ontario to treat breast cancer that has metastasized to skin?
So I've never heard that word electrotherapy. It makes me wonder whether it's something weird and wonderful. There is something called electron beam. Electron beam is a kind of radiation that radiation oncologists use that's meant for very superficial cancers like skin cancer, from golfing too much in the sun. That has been available for eons. And it's meant for cancers on the outside surface of the skin to help them. Are you guys aware of I've never heard of electron therapy?
I haven't heard of it either. And when I looked it up, the electrochemotherapy came up as something that I also am not familiar with. But then more specifically looking at what are some additional treatments, particularly for skin mets. So, and maybe you can speak to that as you have with the radon beam therapy.
Yes, so skin metastases generally reflect a disease process. So generally it means the disease is kind of in the whole body, hiding somewhere, if not evident. So we use medications. We know that person would be destined to have further recurrences later in other parts of their body. So we treat them with medicines like we talked about, anastrozole, letrozole, CDK46 inhibitors. And as they shrink, we know they're working. So it's kind of, an easy way to monitor the disease. I had one woman that luckily only had one skin tumor, and she was so upset by it psychologically. You can have 5 in your liver and you cannot see them, and they don't have the impact as one that you can see on your body. So I really felt for her, and it was getting better. It was very well controlled, but we had it removed surgically because that way it put her mind at ease. And she's still been fine for 3 more years. So sometimes surgeons can just take them out. That's true if there's 1 or 2. If there's many, obviously it's not feasible. There can be 100 sometimes. So if there's many, the treatment is always medications. Medications go everywhere and it can help those tumors. If there's a few, then radiation can help as well. You can't give radiation to the whole body usually, but if there's one contained patch where there's lots of them, or 1 or 2 large ones, particularly if they're causing pain or bleeding in a certain location, they can be radiated. to palliate them and really help people feel better.
Mm.
And that's kind of, those are our routine options.
Mhm. Thank you. I'm going to have another question that was sent in. It reads, I had 3 positive lymph nodes and 26 removed on my right arm, along with a mastectomy on my right breast. My oncotype test said that chemo would only offer a 2 to 3% better chance of the cancer not returning. And given the toxicity of chemo, my physician recommended not having it. I also did not have radiation. However, I have not met any other patients who had a similar experience, and I'm wondering if taking exemestane alone, wow, this one is a long one, is enough to reduce my risk of recurrence. What else would help reduce this risk? So I guess this is a very specific to the patient question.
It brings up some general issues though. So the exemestane is one of the aromatase inhibitors, like letrozole and anastrozole. So that is, again, the most important treatment pound for pound. It offers the biggest preventive value of any treatment that we have, more than radiation, more than chemotherapy. So she is getting the most important treatment. Doesn't matter which pill, there's 3 of them, they all work pretty much the same. The other issue, if you have 3 lymph nodes, often radiation is given, but it varies by the patient. So there probably are unique circumstances in her. The radiation doctor might not have pushed it, but they often will offer it depending on the patient. If that patient has reasons why the radiation might be more dangerous, the body shape, how much lung might be exposed, for example, she would probably have to ask her radiation oncologist. Those types of treatments only really help if they're given within 3 months or so of the operation. So it wouldn't help to go back and look at it again now. But there may have been unique reasons why. Even after mastectomy, if the lymph nodes are involved, they often talk about radiation. If there's more than 4 lymph nodes, they often will push radiation. Less than 4, there is some value, but it's case by case. The other issue is, what about the chemotherapy? Well, I'm sure Jen and Kathy, you've heard of the Oncotype data. Oncotype has been used since about 2010 in Ontario to help decide for people whose glands are clear if we can avoid chemotherapy. And it's been really nice because we used to have to give chemo to most people. And now we can avoid chemo in many of them because that gene signature says that person's risk and benefit is not worth it to get chemotherapy. So in the lymph gland positive setting, that data is hot off the press. It just came out in December at San Antonio. And they looked at people with 1, 2, or 3 lymph nodes and looked at oncotype. And if the score was quite low, chemo didn't seem to add anything. So it also depends on age. And I'm not sure when she had that test done. The data is different post-December than pre-December. If you're past menopause and the risk score comes back low for oncotype, chemo doesn't really add very much. If you're younger than 50 or premenopausal, it probably still has benefit. So today, if she is 45, we would have still recommended chemo even with a good oncotype. So things are in very rapid flux these days. The other caveat is in that study where people had good scores, didn't need chemo, there were very few people with 3 lymph nodes. Most of them had 1 or 2. So we're not sure how confident we can be that we can avoid chemo if they have 3. So when you have 3 lymph nodes, if we do oncotype again, we go back to basics. What are the pros and cons? If that person has other health factors that make chemo more dangerous in the COVID era, if we suppress someone's immune system, are we worried they might get COVID and not survive it? There's many factors now that we have to look at case by case. So in a nutshell, if she's after menopause, her advice was quite correct. The benefit will be quite small. If her oncotype score was very low, all the more maybe chemo is not needed. If it was middle pack or high though, or borderline, that might be a different discussion. 3 nodes is just on the fence, so it's really hard to know for sure. But again, it really is individualized, and she probably had other factors related to age, health, fitness for chemotherapy, maybe the COVID numbers in her area, they all may have come into play. It's always about what's the good and bad of chemotherapy and how do they balance out. I had one lady years ago, before we had that data from December, who went to Florida every year. This is back in 2017. And she said, I'm not spending the winter in Canada. She's wealthy. She had a nice place down there. She had, I think, 2 nodes positive, and it was hormone sensitive breast cancer. So she did the oncotype. In that era, we had retrospective data that was not as high level evidence from Israel, Germany, America, suggesting that if your risk was really low oncotype, chemo probably wasn't necessary. So she paid for the oncotype out of her own pocket. That's about $4,000. And the score came back low. And she said, well, I'm going to Florida. I'm not having chemo. And I actually felt better. I didn't lose sleep over her. She would have paid to get the chemo in Florida if she had to. She wouldn't stand winter in Ottawa. So it kind of just illustrates again that, you know, patient values are very important. How big a bang for the buck is worth it for her to stay in the winter.
And I assure you, Dr. Sehdev, she did it because she didn't want to lose sleep either. She's
Yes.
like, I got to get this. I got to know the answer. I got to go.
Exactly.
Let's do this. I guess. Jen, I'm going to give you an opportunity to do a live question now.
Yeah, so we'll do a few more live questions. We're trying to sort of combine questions because there are so many.
So many.
Which is great, but we're going to try and get to a few more here. A couple more questions back around tamoxifen, and when we're speaking about compliance. So what is the minimum effective dose for tamoxifen?
Yeah, that's a neat question because
cut it back, scale that back a bit.
So it's a really neat question because you know, the dose is usually 20 milligrams a day. And all the studies that prove it works to prevent breast cancer recurrence or treat breast cancer are all with 20 milligrams, really. So I think it is a gamble to play with it, to mess with it. If someone has to go on a lower dose, I would rather my patient try a different drug than take a half dose. Now, what are the caveats? So I use 160 milligrams to treat melanoma. Metastatic melanoma, it was part of a regimen called the Dartmouth regimen with chemo. And, you know, it wasn't fun. There was a higher risk of blood clots, you can imagine, but we did it routinely. So, you know, and it wasn't that much worse. So we don't know the optimal dose. The one thing that's interesting is there was a study that was kind of food for thought. It wasn't a perfectly done study, but in patients with DCIS, we call it stage 0 breast cancer, like a pre-cancer, where cancer cells are in the ducts, but not yet invasive in the breast. They looked at patients who got 5 milligrams or 10 or 20, and the lower doses seem to prevent getting a real breast cancer equally well. So we have some kind of you know, food for thought that maybe a smaller dose might be as good. But when we're talking about real breast cancer, where the goal is to save life from incurable recurrence, you know, I would rather take the proven dose whenever possible. Sometimes the patients have to cut the dose. We say, well, try that or try 20 every second day. And later on, when your body has gotten used to your side effects, if they're doing better, let's try to work back up again. And most often we're successful. So that's kind of my feeling. I think if patients have to take tamoxifen, you know, they're too young for a aromatase inhibitor, we look at other options. If someone's 40 and they can't take an aromatase inhibitor, it's quite reasonable just to do the oophorectomies. Again, it's a one-time procedure. It is invasive. It's no worse than a tubal ligation for contraception. And that oophorectomy to put people into menopause is as good as tamoxifen. It has the same impact by itself on preventing a recurrence that tamoxifen does. So that option is often a good alternative, and there's no drugs at all after that. So it really has to be case by case, but I would say when you're dealing with preventing incurable disease, we try to go, you know, with the best evidence we have, with the proper dose, or we try to find an alternative.
That's helpful understanding sort of what that recommended dose is and why that's what all the clinical studies have been done.
Yeah, I think patients sometimes feel that we don't care about them if we say, well, just take the 20. We really have to make sure people know we care about their side effects. We need to work on a team to make them manageable. But also, particularly if someone has an average or high risk breast cancer, that may be having some side effects like hot flashes a couple times a day that don't disturb sleep, for example, maybe they're worth it, you know, to help keep the cancer away. Easy for me to say, but
No, but
That's helpful
yeah.
to know.
Yeah.
Question around, is there an alternative to the Zometa infusion?
So Meta is used for, I mean, again, we like to use the real name, so zoledronic acid is the real name. The brand names are no longer used because that's not what we use anymore. Those brands have all changed now to other brands. So the real name is zoledronic acid. And we're talking about mostly about early stage breast cancer. So we give that drug about 6 times, twice a year for 3 years to help prevent metastases from occurring. It actually makes the soil in the bone less fertile for cancer cells to grow. So it largely prevents breast cancer coming back in the bones, one of the favorite places, by another 3 to 4% less. It may also prevent cancer coming back in other parts of the body, other breast cancer metastases. So we do it that way. If you're taking it for bone metastases, like people are suffering with bone seeds of cancer, there's an alternative called denosumab. Denosumab is given by GPs twice a year as a bone strengthener. That's called Prolia. When we give it for bone mets, we call it Xgeva. The dose is 12 times higher. So there's an alternative to zoledronic acid if you have cancer in your bones. The denosumab may be a bit better at preventing fractures, pain, paralysis from bone damage. It may be a bit better, but it's not paid in most jurisdictions. It's about $500 a shot. For the prevention, for the adjuvant setting, we only really have good data for zoledronic acid, so life is simpler. It's a 15-minute intravenous infusion twice a year for the 3 years. And that's the one we have the evidence for. There was a study of denosumab twice a year also. It showed a trend to some benefit, but it didn't quite meet the cutoff. So it's not been adopted.
Okay, I think that's helpful to know. Kathy, I think you're done.
I'm done with my questions.
So there's a couple more here around the difference between Oncotype DX and Mamaprint. And does it matter which one patients are receiving if they're having those tests done?
Well, there's others too. There's PAM50, there's one called EndoPredict, and it's a big question. If the same patient in research studies gets 2 or 3 of them done, they often don't agree. So it's a bit spooky when you're making your decisions based upon these tests. They all look at somewhat different genes, and the genes help tell us about how aggressive the cancer is, how sensitive it might be to chemotherapy, how active the estrogen pathway is, for example. So they've all been proven to work when used according to the trials that developed them. That's what I can say for now. The Mamaprints and the Oncotype are probably both used in Canada. I don't think Mamaprint is routinely funded yet in most Canadian jurisdictions. In Ontario, there's a pilot. We can get it right now compassionately or free of charge from the manufacturer. So they're a little bit different. EndoPredict, and there are a lot of subtleties to these conclusions, so I don't want to maybe use too broad a brush, but it's meant to do 2 things. It's meant to tell you what's your prognosis for the cancer recurring in your body incurably, and how much better can chemo make that. So if it's a bad cancer, but it's not very chemosensitive, chemo won't help anyways. And it's helpful to know that. Mamaprint has mostly been shown that it's prognostic. So it can tell you what's the risk of recurrence. But whether it can tell you that chemo works or does not work is still somewhat controversial. We don't have that same level of prospective comfort that it can help tell that question. So right now, for example, we have Mamaprint for free if it's in 1 to 3 lymph nodes. We don't have Oncotype funded. So I would use it there. And if it comes back very good, I might feel comfortable not giving chemotherapy. They all have somewhat different pros and cons, but I would say most of our guidelines right now recommend we apply any of them. The Oncotype DX tends to be the most widely used internationally. The Mamaprint is less expensive. One day it can be adapted to be done at local academic centers across large cancer centers in Canada and not be shipped to the States, for example. So there are some pros and cons, but we still have to flush that out. Mamaprint has an interesting cousin called Blueprint that's done with it. And the Blueprint can sometimes tell us that an estrogen sensitive positive, estrogen receptor positive breast cancer may actually have a genetic makeup more like a triple negative breast cancer in up to 15% of higher risk breast cancers. And maybe theoretically, we need to treat those people more like triple negative. And that's just theoretical. We don't have good proof for that yet. But we think we'll have a lot more information about how to use these tools just in the next 5 years. Right now, they help us really tell who needs chemo and who doesn't. The biggest advantage of them has been for Oncotype, we've been able to spare women getting chemotherapy who would have had chemo before, especially if their glands are negative, their risk is low. We can feel very comfortable that A, chemo is not necessary, and B, it probably wouldn't add much anyways. And the side effects might be as bad as the benefits. It actually has really cut down on chemo volumes in many centers because now we can avoid it.
Yeah, it's amazing to have seen that. And a lot of, to your point, in terms of what's accessible and what's covered, oftentimes dictates a lot of the tests in Canada right now. So
Oncotype, I think, is funded across the country for lymph gland negative, right? So
Right.
that now.
The others, not necessarily right across the country. So
yeah, there are some gaps. Oncotype has prospective randomized trials supporting them. So, I probably, if I only could have one, it was my family and they were in a different country, they only got one or the other, I probably could live with either of them.
I know we're coming to the end, Jen. I know we're coming to the end. I have one very quick question, and if you could answer it very quickly, out of just, simply just to know, and over the time you've been a clinician and an oncologist treating patients, do you find that patients are much more savvy and understanding their diagnosis since the time you started?
Yes, definitely. And I think it's largely dependent on the patient population, the education level, the socioeconomic status, the patient interest, but overall, for sure. Okay. And even patients, like I like patients that have homework. I like them to go home with something to read. We had that great book, Breast Cancer from You. I still want to redo it again to make it up to date. But we used to give people paper homework. I used to circle the sections that were related to their cancer. I used to mark in the margin their size, their grade, their cancer features, and I crossed off the ones that aren't above theirs. Now they go on the web. And on the web, I can't really customize it. I can't cross off the wrong parts, so it can be overwhelming. So the problem is now, I think, is too much information.
Right.
And people are overwhelmed and they can be very stressed. One patient had a 5mm tumor that did not need chemotherapy. It was a very well-behaved tumor, but going online, she was so frightened. She ended up going to the States and paying for it because she just wanted it and was so scared. So, that can be a dilemma. How do we balance that? So I like to give people now homework. We have an online portal where patients can read my notes and my results. And I actually try to put websites that are reputable, that are well-written for them so they can look to those and get useful information.
Thank you. That was an important question to me because we are conducting an education session. Yep. So thank you.
Sure. Yeah.
Jen,
I think we have time for one quick question. That's one, and actually specifically around, again, ER positive breast cancer. Is there any situation where patients would not be advised to take hormone blockers?
So I think if someone has an ER positive tumor, just like with chemo, there's an equation of good and bad around the treatment. So if they had a very small tumor, 5mm or less, the value is pretty minimal. We use these anti-estrogen pills in people with DCIS, with stage 0 precancer. We use it for them too, to help prevent them ever getting a full-blown breast cancer. So it's still there, but the value is less. If people have a contraindication, meaning something in their health that would make it more dangerous, they had a previous blood clot, or a dangerous blood clot in their lungs for no reason. If they had severe osteoporosis and had a fracture, when they were 72, maybe that might make for a small tumor, it would make the bad more than the good. If they had a bad breast cancer, though, we would just go ahead anyways and give them bone strengtheners and help monitor them very, very carefully. So it really is individual. I think, except for those very, very small tumors or pre-tumors, though, most patients would benefit from treatment.
I think that's helpful and a great way to sort of wrap this up. I feel like we could discuss this for
I
another
know.
half, but
The other closing comment I'd say is that, people get so sometimes frightened because of so much information. Colon cancer patients get adjuvant chemo routinely for colon cancer. And the knowledge is there, but the anxiety is not the same. Even if it's a female, same age, it's not the same. I think it's because of the Hollywood awareness of breast cancer, the amplified signal because of too much information on the internet. It raises the anxiety level. In general, we have to remember that these things are largely a blessing. We're grateful we have these treatments that can so dramatically help prevent fatal recurrence of breast cancer. We wish we had them for kidney cancer, for pancreas. Like, we don't have good treatments for prevention. We just have to take our chances. When I was younger, we tell a lot of these women, see you back in 6 months, we'll do a checkup, mammogram next year. Life was easy. They were happy, we were happy, but a lot more of them would die of recurrences. So I think we should be, thinking very positively. We're grateful we have these therapies available to us.
That's well said. Excellent.
that's a great final thought.
Yeah,
And,
yeah.
So on that note, I think we'll conclude for today. Thank you to everyone who joined us for your excellent questions. It was a great discussion. Thank you, Kathy and Dr. Sehdev, for answering all these questions and for this very lively, I think, and helpful discussion. We will be sharing a short survey with all participants and would really welcome and appreciate feedback on this session. And thank you again for our sponsors today. Our gold sponsor is Viatris, our silver sponsors, Pfizer Oncology and Roche, and our bronze sponsors, AstraZeneca, Knight Therapeutics, Merck, and Ontario Trillium Foundation. And thank you again. We look forward to the next Q&A session. Dr. Sehdev and Kathy, have a great day. Thank you, everyone who joined us virtually.